Hello again, this is Paul Barach coming to you from Hospital Management Asia 2015. This is the module podcast on critical open disclosure skills after adverse events. The objective of this podcast is one, to describe the processes involved in clinical incident management, and particularly objective two, to discuss the importance of the incident reporting after the event and how to deal with the fallout, and finally, objective three, to discuss coping strategies after being involved in an adverse event. Adverse events happen on a regular basis. I'd like you, as you listen to this podcast, to think about an incident in which you were involved in which a patient was harmed. I'd like you to think about what happened, what was the error, what were the system elements that came together, what happened next. Think more about the facts, not how it felt. We'll be dealing with the feelings and emotions later in the podcast. What do we know about errors? Number one, everybody makes errors. Even experienced clinicians make errors. Number two, we work in high-risk situations that increase the chances that we'll make an error. Number three, we can avoid most errors by practicing low-risk behaviors in systems that are highly resilient. Number four, culture always affects how we behave, and our behaviors determine outcomes. Number five, most near misses and significant events are due to systems or organizational processes that come together to undermine clinical actions. We know that an incident may have been caused because something has gone wrong during the patient's episode of care. It could be because the outcome of the patient's illness or its treatment did not meet the patient or his or her doctor's expectations for improvement. Or it could be from a recognized risk inherent to an investigation or treatment, for example, a neurotoxic drug. Or finally, because the patient did not receive his or her planned treatment, or perhaps because they chose not to take the medications or to follow the course of action that was recommended. We can deal with all this under the rubric of enterprise risk management. ERM, as it's called, is all about reducing risk that can be achieved by either eliminating the risk, by preventing certain actions, or by protecting the system or the patients against these outcomes. Sense-making and resilience, as discussed earlier in this program, serves as conceptual frameworks for bringing together well-established approaches to assessment of risk and hazards. This can happen at the single event level using process maps and root cause analysis, as discussed earlier. It can happen at the organizational level using failure mode and effects analysis, and it can happen at the system and macro system level using probabilistic risk assessments or PRAs. The results of these separate or combined approaches are most effective when the end users, the clinicians, in conversation-based meetings add their expertise and knowledge to the data produced by the RCA or the FEMA or the PRA in order to make sure that it makes sense to them in how they approach, address, and ultimately tackle risk and hazards. It's very clear from enterprise risk management that without ownership by clinicians, engendered by such conversations, the possibility of effective action to eliminate or minimize these hazards is greatly reduced to minimized. So what should happen after you're involved in an adverse event? Number one, assessment and treatment of the patient to minimize present or future escalating harm. Number two, open disclosure to the patient and the family about the events, and we'll discuss that in just a moment. Number three, identification and notification of the adverse event to the hospital authorities. And finally, reviewing of the circumstances and contributing factors that might have led to these events in order to ensure that these events, or at least the sequela that led to these events, do not recur again. I'd like to introduce the concept of open disclosure as a mode of open communication. What we mean by that is that when things go wrong in healthcare, multiple things must happen. Number one, there must be an authentic expression of regret. Number two, there must be a factual explanation of what happened to the patient, the family, or their guardians. Number three, the consequences of the event must be discussed and managed. And finally, clear and unambiguous steps must be taken to manage the event and prevent a recurrence. What's interesting about studying adverse events and the consequences around disclosure is that most studies show that most providers, perhaps as high as 90%, do not report adverse events. This is what David Bates and Lucian Leap and David Cullen showed at least 25 years ago. We also know from studies from junior physicians in training, registrars, and residents that there are a series of reasons why doctors may not report adverse events. For example, feelings of shame or guilt, fear of punishment and retribution, membership of a profession that values perfection versus authentic communication about failure, systems factors, inadequate or no feedback, time constraints, a lack of true confidentiality, a failure to respect or have faith in the process, and finally, most disturbingly, a lack of knowledge on how to report these adverse events. The Junior Medical Officer study from Australia from 2007 showed there were a series of reasons why doctors may not report events. These are some live quotes. "I don't like to fill in an incident report. It seems like a lot of effort for no outcome. There doesn't seem to be a point in writing an incident form because you never get any feedback. I don't know the process of what happens after the reporting of an error. I don't want to get somebody into trouble, including myself. I don't have any faith in the no-blame policies. I think when it comes down to it, you would be alone and you'd be punished. I want to know if I've made a mistake, to address it and to continuously improve, but that doesn't happen. It's frightening not knowing what's going to happen to me if I report an error, and what it means to my career. Am I going to get in trouble?" Albert Wu many years ago introduced the concept of the second victim. If you were involved in an event, you a nurse, a doctor, a pharmacist, or a manager, how would you feel? If it wasn't you, how do you think the doctor felt? Wu and others have shown this significant, extraordinary emotional response to what happens to providers when they're involved directly and indirectly in initiating or propagating an adverse event. We have seen from multiple studies how this has changed careers of providers and has been akin to a post-traumatic stress disorder, undermining the ability of providers to perform. In another study done by Newman in 1996, providers were asked, in response to their mistakes, 63% said somebody to talk to, 59% reaffirmation of their professional competency, 48% validation in their decision-making process, and finally 30% said reassurance of self-worth. This is clearly a difficult issue. Bob Lennon from the Harvard School of Public Health showed many years ago that when patients were asked if their providers had told them about an adverse event that were caused to them, would they feel better about the physician? The majority of the patients said they would. When the physicians were told the exact same scenario, how would you feel about an incident in which your patient was told about an event that you caused to them? Would they trust you more or less? And the providers said, trust you less. A very interesting dissonance between what the providers feel about open disclosure versus what the patients feel about open disclosure. The formal definition of open disclosure is as follows: informing patients and their families of bad outcomes of medical treatment as distinguished from bad outcomes that are expected from the disease or injury being treated. Mike Cantor and others have shown the key principles of open disclosure to include, number 1, an openness and timeliness of good communication. Number 2, acknowledgement of the incident. Number 3, expression of regret and an apology. Number 4, recognition of the reasonable expectations of the patient and their support person or persons. Number 5, clear and unambiguous documentation about the event and the follow-up of the event. Number 6, support for the clinical staff. And finally, confidentiality of the documentation. Barach et al. Showed that effective open disclosure includes acknowledging to the patient and their support family when things go wrong, listening and emotively responding appropriately when the patient or their support persons relate their experiences and concerns, the opportunity for the patient and the family to ask questions and to have those questions answered, and finally, providing support for patients and their support persons and healthcare staff to cope with the physical and, perhaps most importantly, the psychological consequences of what happened. The 5 essential elements of an open disclosure training program for your facility might include an apology, I'm sorry, or we're sorry. Number 2, a clear and unambiguous factual explanation of what happened, not just orally, but also written down for the family. Number 3, an opportunity for the patient to relate his or her experiences. Number 4, a discussion of the potential consequences to the patient, both during the hospitalization and afterwards. And finally, an explanation of the steps being taken by you in the system to make sure these events don't happen again. We define an apology as an expression of sympathy or regret, or of a general sense of benevolence or compassion in connection with any matter, whether or not the apology admits or implies an admission of fault in connection with the matter. An apology does not, I underscore, does not constitute an admission of liability. It usually will not be relevant to the determination of fault or liability in connection with civil liability proceedings, and it cannot be adduced into evidence. This clear and unambiguous legal definition allows us providers to acknowledge forthright to the patient that, in fact, an adverse event occurred and to be fulsomely accountable to them in that regard, while we're still trying to understand how these events happen, how do we prevent them from happening, and how to continue the care of this patient. We know that good open disclosure programs suggest that there should always be an early meeting between the patient, family, and treating clinician as soon as after the event is discovered. Number 2, it must occur physically close to where the event happened in order to ensure that where the events are fresh and alive in the memory of the patient, family, and providers. Number 3, any clinician may be responsible and should therefore need these skills for leading this type of discussion. Informal processes where the treating clinician and or clinicians provide information and apologies, and finally, a process may stop there or be linked to an ongoing communication and formal disclosure once we know more about why these events happen. This formal open disclosure is a structured process that may follow on from a clinical disclosure. It requires careful planning and preparation. It involves the appointment of a coordinator and an advisor on the open disclosure team. It may occur over multiple meetings, and finally, it will usually include the sharing of the data and the whole investigation outcomes. This is essential if we're able to gain back the trust from the patient and their family. Open disclosure advisors have been coined as a term. These are senior health professionals who have received intensive training in empathetic communication skills and are available to support the process within their facility. This may be an impartial third party, that is to say, not necessarily the clinician who was involved in the adverse event, but another clinician from the staff who facilitates the formal meeting with family and or the patient. Another key element that patients and providers ask about is that who's going to reimburse our expenses? One of the cornerstones of a good open disclosure program is to consider supporting an early offer and approval for reimbursement for reasonable out-of-pocket expenses, such as travel, food, support for childcare, etc., incurred as a direct result of a patient safety incident. This includes practical support. It sends a strong signal of sincerity and may be raised at a formal open disclosure discussion, if not already discussed during earlier clinician disclosure. It is generally accepted that the practical support offered through reimbursement does not imply responsibility or liability, but simply is good business practices. Reasonable out-of-pocket expenses, again, may include but are not limited to accommodation, meals, travel, childcare, and anything else the patient or provider raises. I'd like to tell you a short and brief example before we wrap up. This is the Modern Hospital in Queensland, an important program that was led by the Cognitive Institute in Brisbane, in which they introduced a clinical incident management program in which providers were introduced to these following elements. At the cornerstone of this training program was a communication program that said thus: Number 1, colleague-to-colleague support will be available. Number 2, acknowledging how difficult these conversations are. Number 3, recognizing how clinicians have little training in this area. Number 4, recognizing the distress the clinician experiences when endeavoring to disclose an adverse event. And finally, that colleagues can provide as little or as much support as the clinician needs in order to help them restore back their confidence, their sense of wellness, and being able to be back in practice. This program includes a half-day open disclosure and communication training skills. The program that the Cognitive Institute have done, and perhaps the leading group in the world over 10 years in Australia, New Zealand, and Singapore, has shown that it's addressed the psychological needs of the parties, the safety and quality agenda, including regulatory requirements, compensation and restitution as required by legislation, and finally, addressing the regulatory requirements. Perhaps the single most important thing that this program by the Cognitive Institute focuses on is a strong focus on senior clinician support. This is hugely important to ensure that colleagues feel respected and supported throughout this very difficult journey. You can see in this slide the total payouts after adverse events went down from 501,000 to 384,000, in this case in Tan Tock Seng Hospital in Singapore. It's very clear from this process control chart that clearly introducing early and open disclosure programs can lead in a drop in financial risk management claims against the hospital. In summary, in my final slide, I'd like to talk about the key principles that we discussed today that are essential to an open disclosure. Number 1, an openness and timeliness of early and often communication. Number 2, acknowledgement of the incident in all its details. Number 3, a robust expression of regret and apology. Number 4, recognition of the reasonable expectations of the patient and their support person. Number 5, clear and unambiguous documentation, both in the medical record as well as giving the patient and the family a clear analysis of what happened. Number 6, and let's not forget the staff, a clear support for the staff in order to deal with the issue of second victimhood. And finally, confidentiality around this event to ensure that people feel authentic about who's communicating and what and how we're sharing this information. Thank you.